Well, good afternoon, everybody, and welcome to today's PLT, hosted as ever by Mel and myself. Hopefully, we have a good session today. Just a couple of things that we wanted to touch on before we got started with today's speakers. First thing that we just wanted to mention was in terms of the training courses that we're putting on at the moment, a couple of things that we've noticed recently. Number one is courses that we're putting on for HCAs and healthcare support workers. We don't seem to be getting much uptake on those at the moment. So if you want to have a word within your organization and just see if there are people that need to go on training courses that perhaps aren't aware of registering with the Training Hub website, and just keeping an eye on those. At the moment, the only things that we tend to be getting significant interest in is phlebotomy. So, just in terms of some of the other offerings, in particular around IMS and VACs, we're not getting much uptake at all. The other thing that we wanted to touch on as well is we're also noticing a significant increase in the number of didn't attends. So people who book onto a course and then on the day don't let us know that they're unable to attend or just don't pitch up. It's having quite a big impact. We had a training course last week where we had 28 people registered and 13 people didn't turn up. So that has an impact two ways. Number one, it makes the average cost of the training course go up significantly. But also it means that in particular on those courses where we are oversubscribed, we have a significant number of people that are missing out on being able to attend. So we've had conversations internally and we are monitoring people that regularly don't attend training sessions. And the bad news is that moving forward, we will start blocking those people from using the website. Obviously, that's going to have an impact. We don't want to go down that route, but sometimes we kind of have to. So that will be a new thing that we'll start up with. We have done it a little bit in the past, but now we're going to get quite tight on that. So the rules that we have in place are if you book onto a course, if you can't attend, as long as you let us know at least 7 days in advance, that gives us the opportunity to open it up to other people to try and fill your space. If you don't, then you're going to be marked as a did not attend. So obviously we appreciate that some things happen last minute, but if we could just all try to be a little bit mindful of that, that would be very, very appreciated. Mel, have you got anything else that you wanted to add?
No, I don't know. Like Craig just said, if it obviously if something happens on the day or you're unwell, as long as you contact us, we'd appreciate that. It's the people that don't contact us and just don't turn up, that it's been a real issue with. But no, I think you've covered everything. We are going to do a feedback form today. So Craig's going to put something in the chat, and then if you fill that in, you will receive a certificate for today if you need that towards any CPD. In terms of that, there is a question in there about next sessions. So we've got March's session sorted. It's already online, so please do start registering for March's session. The next date after that's going to be May. Currently, we're looking at what we want to put on. So the more information you let us know, the more I can adapt it to what you actually want. I think that's about it. I
Perfect.
think we
What
could
I will
probably,
do is I'll send out the link to the form as an email to everybody who attends today. So you will get that come into your inbox. If you could just take a couple of minutes to fill that out, it would be very, very appreciated. Perfect. Question, Abrer, are you ready to get started on your session?
Yes, Craig, I am. Just can you see me? Hang on. Yeah, here we are. How's
There
that?
we
Yeah.
are.
Can you see me? Yeah. Hi, Craig. Hi, Mel. How are you both? You all right? Yeah, good.
Not too bad,
Fantastic.
thank you.
Yes, all good from my side of things. I'm happy to take over. That's okay. So yeah, good afternoon, everybody. I'm Ibrah Jan from Kies Limited. Today we have a great agenda today, looking at respiratory case studies and effective COPD patient management, led by our guest speaker, Pauline Gray. Pauline Gray is a respiratory and primary care educator and a nurse, advanced nurse practitioner. She's from the Lincolnshire area and she brings a wide range of expertise. I'm sure some of you already know the name. Pauline has done some work in Northamptonshire as well. In terms of background, during Pauline's professional career, she developed a passion for respiratory care and education. Primary care gave her a different focus and enthusiasm for respiratory care pathways. Continued. This progressed into respiratory specialist role with key responsibilities for delivering health improvements and education to general practices across Lincolnshire and Leicestershire, achieving service developments and awards for this work. She's developed an independent business educating nurses and clinicians across Midlands with the ultimate aim to influence better care, patients, and increase knowledge and confidence of practitioners. Continued clinical practice in respiratory care pathways and paramount, including clinical ANP sessions and education mentoring to practices PCNs locally within the Lincolnshire area. So prior to myself passing on to Pauline, I will do a short update and obviously just a few housekeeping things before we continue. I'll do a little update on the brand that I promote, Trimbo, in asthma, although today the session is in COPD, so I thought it's a good opportunity to mention that to you guys. Q&A side of things, Pauline is more than happy to take Q&As throughout the meeting. If you can just put the details in the chat function, then we can try and get Pauline to answer as she's going through. There is also a dedicated Q&A at the end at 1:45 for 15 minutes, where the meeting will then close at 2 o'clock. Prescribing information is also to hand for our brands, and that will be in our presentation also at the end, and it can be provided at any time. And like Mel said earlier, you know, feedback is quite important for us as well. So we value that in regards to that. And obviously this meeting is for healthcare professionals only. If there's anyone who's a member of public, I'd advise to leave the meeting, please. But yeah, without further ado, I'll just share my screen. That's okay. Just to check, Mel, can you see the screen share at the moment?
Not yet, no.
Okay, we'll do that once more. Okay.
Doing something now.
It was doing something, yeah. I think I should have waited. We'll do it again, it's fine. Oh, that's right. Yeah, here we are. All right, it should be just coming up right now.
Yeah.
Yeah, here we are. Then I can get my screen up. Is that okay, Mel?
Yeah, that's perfect.
Perfect. So, as you aware, Trimbo's the only extra fine formulation, ICS, LABA, LAMA, all in the one device. As you've been prescribing the brand in COPD, we also have an asthma license as well. And obviously being an extra fine formulation is designed to reach the larger and the smaller airways. But I think when we talk about demographics and statistics for asthma, it still remains a huge burden in the UK. 7.2 million people living with asthma in the UK. 4 deaths a day occur each day from an asthma attack, and 30–50% of patients with moderate or severe asthma remain inadequately controlled despite their ICS LABA interventions like Foster and other ICS LABAs. So it's definitely a number to look at. The type of patients that may be suited for the brand are such like, as we can see, as an example, Katie, someone who's had an exacerbation in the previous year, unfortunately having them symptoms such as the coughing, shortness of breath, wheezing, and going for that blue inhaler more than 3 times a week. Unfortunately, quality of life is severely impacted. Obviously, we've got Katie on the picture here. Obviously, it might not be Katie, you know, as an example. So, you know, it might be someone like that. But I think this slide is quite an important in terms of what the BTS NICE and SIGN joint guidelines define as what complete asthma control is. And it's those things on the screen there. No daytime symptoms, nighttime awakenings, the need of going for the rescue meds, obviously no asthma attacks and the rest, as you can see it. So it's really important, you know, to understand that. And that's what they sort of talk about at the bottom there. The BTS NICE and SIGN guidelines define uncontrolled asthma as having any exacerbation requiring oral corticosteroids and all frequent regular symptoms, such as using the blue inhaler 3 or more times a week or night times awakening 1 or more times a week. So it's definitely something there to look at. I think when we talk about the airways, and it's really important to understand how asthma sort of develops and what is happening. So on the left here, we've got an healthy airway. As we can see, the airway smooth muscle, normal airway wall. And then on the right, we've got an increased bronchial smooth muscle contractions happening, which are driven by cholinergic activity. And then obviously you've got the inflammation, which is causing the obstruction and hyperresponsiveness, and the excess mucus obstruction, which is happening as well. Now, the key thing on this page is really about acetylcholine. Normally when I'm in a meeting, I'd ask on face-to-face, you know, what pathway, and then get hands up and talk about what pathway acetylcholine works on. But the actual pathway it works on is the parasympathetic pathway. Why I mention that is because the parasympathetic pathway is the same pathway that the LAMA component within Trimbo also works on. But then obviously having these increased levels and fluctuations of acetylcholine increases activity, things such as bronchoconstriction, inflammation, long-term airway remodeling and mucus secretion as well. But I think if we were to pick out one thing from there, the long-term airway remodeling, you know, that's like if we have a scab and we continue to pick it and pick it and pick it, you know, that structure will never be right again, and it's the scarring of the tissue which causes that. So it's something to think about. In terms of what I just talked about, the acetylcholine, the LAMA component works on the same pathway, the parasympathetic pathway, as the acetylcholine. So obviously, if we're controlling the fluctuations of acetylcholine, the correlation we can make is that hopefully that smooth muscle can get relaxed again. So you've got the ICS, which is treating the underlying cause of asthma. You've got the LABA, which is keeping the airways open. And then you've got the LAMA, which is keeping them opening and also antagonizing the effects of acetylcholine bronchodilation as well. So you've got those things happening there in regards to that. So from a Trimbo point of view, you know, it's extra fine formulation like Foster, familiar in terms of the PMDI device, synergistic effects that we make in regards to that. You've got the ICS, LABA and LAMA, you know, working together on that synergistical site. And then obviously you've got the reduction in moderate severe exacerbation rates which is something in regards to our data. I'm not going to go through data now, just hence the conscious of time. We've got to get Pauline to present as well. But I'm more than happy to take any questions if anyone has any. Okay, that's absolutely fine. Can't see any questions coming through. What I will do is I'll just put my details in the chat function. If you have any questions, feel free to contact me via email, telephone number. And also from our point of view, we do also provide breathing well range, which is peak flow meters, placebos, action plans, diaries, all free of charge. But we'll just touch on that right at the end. But yeah, hope that's been a good update for the brand Trimble, and I'll just pass on to Pauline, who will do the presentation for respiratory case studies in effective COPD patient management. Thank you. To double check. Might be on mute, Pauline. Yeah, I think you're on mute.
Just having a little look, see if I can help with unmuting.
Thank you.
Pauline's set up as a...
Right,
there we
I'm
go.
not
Come
on
off
mute
mute.
now.
Oh, there you
Okay.
go.
Camera on. Can you hear me okay now?
Yes.
My mic is showing that I'm not muted. Can you hear me?
Yes, that's
Yeah.
absolutely fine, Pauline. Yeah, thank you.
You can hear me. Fantastic. Oh, panicked then. I was like, oh my goodness me. Hey, thank you all for having me back. And thank you to Abra for inviting me back to do the COPD arm of patient case management. Really kind of you to introduce me back into your great learning hub. Thank you, Mel, and anyone else that's involved. So I'm just double checking everybody can hear me okay, yes?
Yeah,
Yeah,
we can
perfect.
hear you.
Lovely, that's fantastic. So what I'm going to do is take over and do the presentation today. There's lots of things going on. Abra, do you want me to take control of this?
Yes, please, Pauline. Yeah, that's fine. Yeah, thank you.
Should have that now. Okay, yes. So can anybody see the screen okay still?
Yeah.
Yeah, perfect. Lovely. Just checking because I've been in this situation. I've been talking away before and then nobody can see me. So, yeah, thanks for having me. I'm going to do a brief introduction today on COPD, diagnostics and management. And then I'm going to go into some case studies because we've only got 45 minutes. But I'm really happy for you to take questions all the way through. I'm really relaxed about all of this. It's something that I really encourage you to do. I want you to get out of it what you get out of it, not just listen to me doing a PowerPoint. So let's have a little look at COPD. I'm going to talk about things that aren't in the slide deck and things that are in the slide deck. So I'll look at crossover asthma COPD. I'll look at the new guidelines that we haven't yet got the decks. Just for full disclosure, I'm an independent educator. I'm doing this on behalf of Chiesi for you guys in Northampton. I've been over to your way quite a lot and understand the pathways of care. I continue to work in primary care doing some acute respiratory clinics, and I do advanced nurse practitioning. I'm a big believer in touching patients if you're going to teach about it. My passion is definitely respiratory, both asthma and COPD, but also other lung disease and differential diagnoses. So let's have a look at it. The data that we've got here is a little bit old. So this is from 2012. There has been more data released in the global 2006 2026 guidance, but we haven't had the updated version of that. But we're getting better at finding these patients, I think. So if we look at the epidemiology, there is an age breakdown on that. And I think something to point out, which has increased, is the age breakdown at between 30 and 50. We are getting more patients in that pathway due to many different reasons. Some that we're finding them earlier, we're actually actively looking for patients with COPD. There's drug influence, so inhalation of drugs as well as tobacco really escalates the damage to the lungs. So that age group variation has gone up. So it's just thinking about where we sit with that. And mortality is definitely something that we are very aware of. Looking at the costs, I know it's always interesting to look at costs, they're never accurate, but I always look at this and I think, yes, it costs us a lot of money, but what's the cost to the patient? And I think patients are the ones that are losing working days, not able to function in their daily activities, and actually having a mental impact because of their lack of ability to do things. So for patients, it's more about what can they do and what's the cost to them, isn't it? So we have to think about that as the foremost. I'm very patient focused. Mortality, as I've said, is definitely one of those. Mortality figures are skewed in, I think, by data generally, because it's skewed by cancer, CA lung and pneumonia. Some of those overlap with COPD, so we've got quite a crossover there. And again, these figures are from 2017, so they do need updating as well. Apologies for that, but there is still a huge burden in COPD deaths. And then we've got our patient group who have got comorbidities, and it's what do they get coded as their cause of death. So there's lots of inaccuracies there. Let's have a quick look at what the diagnosis, how we make the diagnosis. So the biggest thing for diagnosis is our history taking, and we've got guidelines that help us with this. We've got two big sets of guidelines, which I will be looking into as we go further forward. So GOLD is now updated. The GOLD 2026 is out. I did have a look at that before I came online to do this, just to make sure that we're pretty much in line. No major changes, but there are some new things coming. So we'll just have a look and see where that takes us. But the history taking hasn't changed. We're looking at progressively worse over time. How is that dyspnea affected the patient? Is it sudden onset? If it's sudden onset, we're thinking other things. If it's progressive worse over time, exertional, having an impact on their daily activities and persistent, we're thinking more down the obstructive lung disease. Have they got sputum? Some COPD patients have, some haven't, as we well know. We have our pink puffers and our blue bloaters, and emphysemic patients don't always produce mucus, so that may or may not be relevant. What other things have we got going on? So there's the risk factors, and we all know about tobacco smoke, but we think about things from smoke from other ways as this is a global guideline, people who sit in countries that have a lot of open fires and are working around that, then that's impacting. We have occupational impact on our lungs. I always talk about the risk factor is an insult to the lung, and vaping has actually been put into the new guidelines to say that we know it's an insult to the lung, but we don't yet know what that impact is. We know vaping's taken the carcinogenic elements out, but we're still insulting the lung. So I always talk about COPD as insulting the lung. So for me, I think we've got things to come with vaping, and that's the general consensus. Things that I don't know if all of you know about are low birth weight. So low birth weight has been proven to have some association with COPD in later life. Thinking about that is really important when you're taking your history. Or childhood respiratory infections. Now that doesn't mean your viral illnesses, or it means major infections within the childhood can impact on that. So still stands the same. And then we look at spirometry, which I'm going to look at in a second, to develop what's going on. This is really thinking about, on this slide, I just wanted to talk to you. We've talked about some of those things on there, but thinking about asthma. So has that patient had an underlying asthma element? We're going to talk about blood eosinophils and how that impacts on what we decide with treatment pathways. And thinking about family history, which we very much do in asthma, but think about it for alpha-1 antitrypsin. For those that have not heard of alpha-1 antitrypsin, it's deficiency in a protein, and it's protective in the lung and the liver. And if there's a deficiency in that, it's a genetic disorder. So we must think about, have we got people who have had COPD, particularly in the younger years, so particularly under 50, but even around 50, have those people smoked? Because if so, with the deficiency, that will have escalated massively. So thinking about that, it's a genetic disorder, as I said. So if you do test for it, I personally always discuss that with the patient, because there's a big impact on whether they're going to have what generational just below them going to geneticists and looking to see what's going on. And the biggest thing that can be done is put into some great programs of care and some great research. We haven't yet got an answer for how we manage alpha-1 antitrypsin, but it's a very important one. So that's all what I wanted to talk around that slide, really, is not forgetting asthma and not forgetting alpha-1 antitrypsin as your biggies when we're doing this. Let's look at a guideline. So we have two big guidelines for treatment and diagnostic, really. And gold is the one that I just said has just been updated. There's not major change in the pathways. So gold is a global guideline, and then we've got NICE, which is our National Institute of Clinical Excellence. So let's have a quick look at how we diagnose. So we all do this. So both guidelines look at spirometry as being after the history taking, we do a spirometry, and they all look to see if we've got a post-bronchodilator, so it's got to be after bronchodilation, a ratio below 0.7. I'm not going to go into Z scores because we haven't got time today, but if we ever want to, we can chat about that. We then categorise what that airflow limitation is, and we look and we see whether we're going forward with a diagnosis. So when you're doing the spirometry, we are looking to see if there's reversibility. We're looking to see if that reverses back to normal. We're looking to see if eosinophils are impacting as well, but I'll talk about that. And then they have an algorithm of care. So we look at this ABE. It used to be ABCD. They've now incorporated C and D into E, and that impacts on how they look. And what they're looking at is risk versus symptoms, not the FEV1. We're looking at the FEV1 for their amount of obstruction, but it doesn't always correlate with their risk or symptoms. So with this, we're looking at the MMRC, which is the modified MRC. In the UK, we have MRC. The global one, if we looked at MMRC of 0 to 1, remember that's our 1 to 2. MMRC over 2 is our MRC over 3. So just remembering that when you're looking at this guideline. And on the risk benefit, they look at whether you've had a moderate exacerbation or a severe exacerbation, and put you into a category for that. So we're going to look at that in more detail. So if we think about the spirometry, we've said that we have an FEV1 FVC ratio of below 0.7 with a negative Z score, and that will categorise them into what category do we think they are. So you can have a ratio of less than 0.7, but an FEV1% predicted of above 80 and still be considered to have mild obstruction. And with no reversibility and no asthma influence, then we're thinking about, okay, we've got some obstructive airways going on. What is the underlying cause? Right, at that point, I am just before I say that, if you have a patient that has a CT scan, we have great access to CT, and I know that you guys do, and the CT scan tells you that you've got emphysema, then you have got COPD. You can have a normal spirometry. it's very difficult. You can't take away the fact that emphysema is seen on a CT. However, if you have hyperinflation on a chest x-ray, that does not give you a diagnosis of COPD. And I'm adding that in because I still get asked that very commonly. And we've had patients that have sort of been on the COPD register, CT scan showed emphysema, but they've got normal spirometry. I believe then patients still need monitoring and looking at annually, because we need to make sure they're okay. Let's have a look at management of COPD. Any questions there about, if anybody wants to raise any hands, chat about diagnostics, please do so. If not, there's nothing in chat that I can see. So if nothing in there and the bra's not giving me any questions, we'll carry on to the management. Okay, thank you. So I'm not going to pinch a bra's great talk on their products. They're a product that I like myself personally as a respiratory specialist. And Trimbo has the PMDI, just to let you know, is licensed in asthma, not in COPD. I have been known to use it off license, don't listen. Right, let's look at the guidance. We've said NICE guidelines are what we use in the UK, but Gold are very great. And I love Gold as a respiratory specialist. I've always worked with Gold because they do an annual update. And the annual update really incorporates new evidence that's coming through, new ideas, biologics in COPD, etc., not being talked about much in NICE because they only update them every few years. So it's really good if you're interested in COPD to keep an eye on both of those guidelines and follow them both. I think they're good evidence-based guidance for us. So as I've said, we're looking at risk versus risk of the patient and reducing symptoms. So I think from a patient-driven perspective, their main focus is how do you get my symptoms better and what can you do to help? We know that COPD patients often don't present until they're quite symptomatic. The lung obstruction and the impact on their symptoms doesn't actually present too early. They can be often have lost 45, 50, 60% of their lung function before the symptoms keep coming through. And obviously patients are losing activities of daily living, they're getting dysfunctional breathing or exertional dyspnea, they're getting more exacerbations, they want to know why. I think as a clinician, my bigger factor is looking at reduction of risk. So of course, some patients will have that, but I want to look at what am I treating my patient with, or non-pharmacologically looking at how I manage them and reducing their risk of exacerbating more. And I'm going to talk a little bit more about that and how I make those decisions as we go forward. We're wanting to reduce exacerbations because with each exacerbation they lose a bit of lung function, and that takes them closer on the trajectory to mortality. So for us, I think that's really an important factor. Let's have a quick look at a couple of guidelines. So we've got the NICE guideline, just to talk you through the two arms of this. So we've got non-asthmatic features. Okay, so this is our patient that has got non-asthmatic features, hasn't got high raised blood eosinophils, hasn't got an atopic history. You've really clearly done a reversibility. You're clear that there isn't an element of asthma in that obstruction that you're seeing on your spirometry. And then we've got our other arm, which are the patients that have got asthmatic features and have got a suggestive of steroid responsiveness. So on the left, we're firstly going to look at those non-asthmatics, offer LABA and a LAMA. So we're looking at giving them bronchodilation. So they're symptomatic, they've presented with dyspnea, let's bronchodilate. And I like to go in with both. Very rarely do I go in with one. If I did go in with one individual, I go with a LAMA as a first line and then I go LABA-LAMA. But LABA-LAMA, let's bronchodilate, maximise as much as we can to get the air trapping out. If they're controlled on that, then great. However, review that patient and see if they're having day-to-day symptoms. Are they having impact on their quality of life? Let's not let our patients tolerate symptoms anymore. I think over the years, and I've been doing respiratory for 28 years, so I can admit that sometimes we had an acceptance that they're a COPD, so they're going to get symptoms. And yes, we can't control and cure everything, but I'm much quicker at escalating treatment and therapies to maximise patients' abilities. So if they're having symptoms, then they're looking at considering a trial of a 3-month trial of LABA/LAMA ICS in the form of a triple therapy. If they don't have a response, then you can take them back down and think of others. That's their symptomology. If we're having severe risk, so 1 severe or 2 moderate exacerbations, which if we know our COPD patients, they get a lot, we then think we need to be looking at ICS LABA with a LAMA, so we'll go straight to triple. So that's on the patients that are non-asthmatics. Patients who've got asthmatic features are always going to be on an ICS LABA. Remember that, always, always. So looking at that, then you need to be thinking about going down the pathway to ICS LABA if they need it. I've just seen a question pop up about SABAs. So yes, all patients who are on salbutamol will need salbutamol if they've got COPD as a background. There is no limitation. We only limit and monitor SABA use in patients who are pure asthmatics. And I think it does get crossed over. So a patient who's been an asthmatic, we've done obstructive monitoring, we've looked at everything else, and we've moved them to asthma COPD with that overlap. They should be allowed SABAs and shouldn't have a restriction. So does that clear that question up? Hopefully it does. So you've got COPD as a diagnosis, they should have access to SABAs, 100%. So yeah, it does get mixed up. So SABA first line, somebody's asking me. Yes, you can do SABA first line. They tend to not do that as much, and I think that came from the latest NICE guidelines. In gold, they still have got that because they don't present until a later in their disease trajectory. But in reality, if I've got a patient that we've found really early, we've found that they've got COPD, we've done all the objective testing, and they're not particularly symptomatic, yes, you can go in with just short-acting bronchodilator, relief of symptoms, as long as that patient knows that if they're using that regularly, we need to go in with the LABA/LAMA. The other thing about just a short-acting beta-2 in COPD, and another reason it's not always considered as a line of management, is that there is some protectiveness from the LABAs and the LAMAs around exacerbation rates. So for me, if I'm answering you from a personal perspective, I haven't started a patient on a SABA only for a number of years. I've given them a background LAMA or LABA to give them that reduction of exacerbation evidence that comes alongside them. And NICE, as you can see, they're just saying that if they're symptomatic, then go in with LABA/LAMA. So I hope that answers it. If it doesn't, then come back to me. But yeah, that's where NICE are sitting. So let's have a look at gold. So we'll have a look and we'll populate this. So this is the slide that I showed you earlier, which is we've got our diagnosis. We're looking at what their exacerbation history is. We're looking at what their dyspneic and their CAT scores are to help us to understand their symptomology. The next slide, I'm going to make an apology already, but I'm going to ask you to focus on the centre part of it. So the writing around the purple and the pink algorithm is really about the drug companies having to put on sort of a bit more information and looking at how they use these environments. So apologies, I did try to get this slide just as how we went forward. So let's think about how we manage this. So a patient who's dyspneic, so a patient who's symptomatic, so just going back here, they in category A and B, okay? We go in with a LABA or a LAMA. They're not saying SABA only there. Like I say, I'd always give them a SABA, LABA or a LAMA, and then straight on to LABA/LAMA. As I've already hinted, LAMAs have a slightly more evidence for reduction of exacerbations. So if I'm only going one, I go LAMA first, bearing in mind you've got to check renal and look at whether they're renally able to do so. 90% of patients are, and we bronchodilate them and we go down that route. So it says here, consider switching device or molecule. They'll always put that in there, looking at the right one for your pathways and thinking of the right one, right device for right patient, right in molecule for right patient. If we think about the exacerbator, which as I said is where I focus, if they're on a LABA/LAMA and they're exacerbating, and they're not asthmatic, then we need to think about in the gold guidelines to look at blood eosinophils. So if their blood eosinophils are over 100, less than 300, then we think about, do we just do, do we need the triple therapy? If they're over 300, they go to somebody's just asking a question. I'll come back to that in a second. If they're over 300, then it's about looking at the triple therapy for that patient. Do I always go on just blood eosinophils? At the moment, I switch between the two. So I don't always just look at blood eosinophils. If we look at the LABA/LAMA and blood eosinophils are greater than 100, they're saying to consider the ICS LAMA/LABA. So we're talking about over 100. A lot of patients are under 100, over 100 in their blood eosinophils. I'm going to not talk too much about biologics, but eosinophils are being very much looked at in COPD at the moment, and there's a lot of things going on. So those exacerbating patients, they're looking, if they're on an ICS LABA/LAMA, we're thinking about roflumilast. It's a bronchodilator. It's a PDE4 inhibitor that comes out of secondary care in Lincolnshire. I don't know, I think it will be the same over in yours. We also think about preventative prophylactic antibiotics. So we're thinking about that azithromycin 3 times a week in that patients. Again, that's coming out of secondary care or primary care if we're awaiting a secondary care referral. And then we've got our biologics, which I'm not going to go too much in, but in the new guidelines, there's a lot of discussion around the eosinophilic element of COPD and which ones of those patients would respond well to biologics. Now, can you remind me of the last question that somebody had put in there? I'm just going back. Still has
Sure,
Severus.
Pauline. It was
Hi.
Gold 2026 Pocket Guide states for Group A 0 to 2 is SABA, and that was from Faisal.
Yeah, there's no reason you can't do SABA. Absolutely. And like I say, it's just that I think the movement has gone that if they're very asymptomatic, just needing an occasional, great. If they're potentially being an exacerbator, I would personally be putting in a long-acting bronchodilator to give them background cover for exacerbation reduction as well. So yeah, it's still there. The pocket guide, it's great to have a look at. Go on and download it. There's some great work in there. So thank you. Yes, that's good. Right, bear with me. I've got to get back to get this to work now. 2 seconds. Okay. So I'm just going to go on to look at where we're going with this. So if we think about all respiratory airways disease, it does have a small airways part that it plays an important. In asthma and in COPD, it has that fine airways that we need to get into, and that's commonly known as the silent zone. And it's important that the lungs are getting the inhaler, the medication, and that can be through device and it can be through molecule. So thinking about that going forward is important. It presents, like I said, in over 90%. So I think I'm not going to go too much into small airways today because I want to do the case studies, but I want you to just think about what molecule are you using, what device are you using. We need it to get to the part that it needs to work in. So thinking about that. Abraz did that. And what does it have a consequence of? Hyperinflation. So those small airways impact on hyperinflation, which looks at the shortness of breath, it looks at reduced accessibility, we look at exacerbation rates. So they're all important things. Those airways need the treatment. So it can have an effect on CV as well. So we're thinking about whether it causes more hypoxia. Does that look at whether we're having some airway backward reversibility? So thinking about the impaired left and right ventricular pathways. So looking at that, that's important. And one of the facts that I found really fascinating when I was looking at the data from this is that patient with a diagnosis of COPD has got double the risk of myocardial infarction. Again, I'm not going to go into it today, but I think we do need to be looking at CV risk in our COPD patients and thinking about them as if we're looking at everybody else, really. That's quite a statistic that I found very fascinating, that we're going through that. So let's have a little look at, again, that just looks at what does the fine particles, where do they reach, what airway do they look at? So that's what we've been talking about previously. Quick look at other oral therapies. So oral corticosteroid is used in end of life or really severe COPD patients, but certainly not for the majority. Theophylline are being used less. So in Lincolnshire, we're using them less. I don't know whether you are over there. Patients who have been on them and are doing well on them, they're carrying on, but they're not used as a PD4 inhibitors are being used more for that bronchodilator effect, more than theophylline. Mucolytics play a great role, as we know. They reduce that exacerbation risk because we're reducing the amount of mucus that airway is producing. Prophylactic antibiotics I've mentioned there, azithromycin Monday, Wednesday, Friday, done in conjunction with secondary care in our area. I have been known to start somebody because it's 12 months to get to a consultant. I have been known to start somebody, but always with a discussion of the respiratory community team who have access to consultations with the consultants, and only leaving them on for the winter, not in the summer, taking them off. Please don't go putting everybody on prophylactic antibiotics, but for those patients that just cannot come out of exacerbation, I have had huge success in this, the same as we do with our bronchiectatic patients. So thinking about that. Nebulizers, as again, we've got nebulizer assessment therapies around here. Nebulizers is definitely kept for that severe end-of-life patient group, not for your general use. SABA with a spacer is still very good and works very well for our patients. With our oxygen services locally, we have great assessments. You're looking for an SpO2 of 92% or less in a non-exacerbatory condition. Then you would be looking to see if they need long-term oxygen to protect their organs and oxygenate so they don't become too hypoxic and that have organ failure for all their other organs. We can use short burst and ambulatory in palliation. I always say for ambulatory, let them do pulmonary rehab first, because actually I've seen through my years of working in pulmonary rehab that we can improve their oxygenation by improving their exercise tolerance and use of the airway. So do that first, and think about where you're going with that. Pulmonary rehab, on that note, please do not ever not consider that. It is a powerful tool in COPD management, and we're going to look at a case study that includes it. I'm going to move on because I want to do your case studies and I don't want you to miss out on those. So I'm happy to take more questions, very happy to take anything going forward, but let's look at some patients. I'm all about, if you've got any patients you want to discuss, I'm happy to do that, obviously anonymously. These are patients that I have seen and are examples of different pathways of care for this group of patients. So this is Frank. He was 60-year-old. He'd had an MI and hypertension. He was a little bit, BMI was 22, so slightly cachectic. He was on Foster 106, 2 puffs BD. So we're thinking about that. He presented with increased shortness of breath over the last 3 years. Just add another question. Brad, do you want to put that one to me? Don't know what that was.
Yes, sure I can. Yeah. From Faisal, in an emergency situation when patients with COPD have been documented to have normal SATs previously, but on assessment during exacerbation, SATs falls in 88 to 92 mark.
Yeah,
Would you recommend oxygen therapy given previous normal SATs? Unsure of CO2 retainer status.
yeah.
Also, I found paramedics seem to be comfortable leaving patient at home if SATs are around 88 to 92%, even when SATs were normal previously.
Yes. I think that's a really good question, and I think it really individualizes to each of the patients. So, in my experience, and when I worked in the community as a respiratory specialist, yes, we would leave patients at home and I would always ask ask them to be assessed for their SATs a week or two after their exacerbation. So that question about when do you leave them at home, it isn't just about their SATs, is it? But if patients desaturate in an exacerbatory state, they do not need to go on to have long-term oxygen assessment at that point. They are given oxygen and CO2 retainers. Obviously, we have to be very careful about what you're giving that patient, what level of oxygen. If they're at home and they're exacerbating and they're not on oxygen, normally you wouldn't need to worry about that. In a paramedic situation, they should be aware of using the correct 28% oxygen mask and monitoring their SATs. So really important question. There isn't a right or a wrong answer. I've had patients that I've sent in who have got SATs of 88, 89, because there's lots of other clinical indicators that made me think that that patient needs to go in hospital. But I always, if they've got a low SATs in an exacerbatory, book them in to have their SATs done again 1 to 2 weeks later, because we need to know what their normal stat status goes back to. Hope that answers that. It's not a straightforward yes or no question, but I hope that answers that sufficiently. Please come back if not. Thank you for that. So let's look at Frank again. He's a farmer. So we've got that other differential diagnosis, complications of farmer's lungs. He is a smoker, 60-pack year history, and no mention of asthma within there, but he's had an MI. So we've got differentials for heart failure. Let's think what we got. So these were the findings. His exertional breathlessness had been worse over the last 3 years, gradually, not suddenly. Suddenly, always think PEs as well. You know, this group of patients are vulnerable to PEs, so thinking about that. CA lung, think about that. Think about if there's an asthma element. He hadn't got a cardiac history, hadn't had chest pain, no palpitations, a very occasional ankle swelling at the end of the day, but no orthopnea, no indication. He'd had 2 exacerbations that particular year, but he hadn't been admitted to hospital, but he had had antibiotics and steroids. He'd had a chest x-ray. He was complaining of a lot of tiredness. He'd got hyperinflation on the chest x-ray, but nothing more significant. Obs was stable. He was 94% on air, so he was fine. His phlegm was thick. He'd got more phlegm at that particular time. He hadn't got hemoptysis. Always ask your question about hemoptysis for every single time, because they don't always come forward. He'd had an ECG, which was normal. He'd had full blood count. There was nil of concern, and his BMP was normal as well. So we didn't go on for echo. So his MRC was 3. So this was how we were. He was an exertional breathlessness, worsening symptoms, not looking like there was a differential in there as to what was coming next. So we summarised that he got severe COPD. What group of drugs would you suspect, and give example of that? That's easier to do in an open room, less so on virtual, so I'm not going to ask you to do that. In an open room, we often do that. What other interventions do you think are important, and how would you approach self-management? So I'm going to give you, excellent, somebody's put up there an answer to that. So yeah, absolutely. So things to do that are non-related to pharmacology, pulmonary rehab, absolutely, smoking cessation, immunisation, really, we're very good at this with COPD, less so. Great answers there. So he falls into category E, and he's having 2 moderate exacerbations and dyspnea. So Trimbo, 2 puffs BD, educated him, went to pulmonary rehab. We love pulmonary rehab around here. I'm sure you guys do. What that gives them is learning about their way that they manage their COPD, as well as having the exercise tolerance improved. And however bad they are, they honestly improve. Having worked in it for years, I've seen patients that could hardly get from the car to the place. So yeah, smoking cessation, absolutely. We've always got to look at that as a plan forward wherever they sit. So all good, great answers. You got them all. I think there wasn't any that you missed. I like that, engaging with lifestyle, medicine, exercise. And I think that if they don't want to go to pulmonary rehab, I always talk to my patients about safely increasing their exercise. And I think it's really important for us to do that safely. This guy had an MI. He had actually been through cardiac rehab previously, so he'd learned a lot about how he moved forward. He didn't want to go forward. He did actually have, that's not on the slide, he was put forward to have a CT scan, but it was after this. Because of his farming background, we actually got a CT scan, which didn't show any interstitial lung disease for him. So he's quite simple, straightforward. So that's all good. So let's look at the next one, Tom, 64-year-old. He came for an annual review in our practice, discussing, as we do in an annual review, just symptoms over the last 12 months. He'd had worsening shortness of breath, more chest infections. I always see that as a red flag. So yes, we know our COPD patients deteriorate. I had a guy who was asthmatic, moved to COPD, all of a sudden got exacerbations increased. He'd got an underlying CA lung, that guy. So always think what's going on, anything else. He was on an open triple, so this guy was on Foster 106 and tiotropium, and that was his standard at the time. Let's see what we found. So questioning on how much is going on. So when we questioned him, he got more phlegm, it was quite consistent increasingly through the year. He did have hemoptysis. Now, what was interesting about Tom, it wasn't his actual name, is that he said, oh yeah, I get a little bit of streaky blood in my sputum. How often do you get that? Oh, quite a lot, particularly over the last month. And it's really interesting to see where we're going with this. Now, patients accept that because they think they cough a lot. They think it's from the back of the throat or the nose. And this was what this guy did. He accepted that he was getting that blood because he thought it was normal. Had he lost any weight? Well, he didn't know. So I asked him about his trousers and he said, oh yeah, I do pull my belt in a bit more. We all know where this is going. When we weighed him, he'd had a stone in loss since his last review. His shortness of breath was much more increased over a minimal amount of exertion. So yeah, I think a couple of you have answered this already. Very exciting, very good. So in our area, we have this guy got a severe COPD, but we always have to think about that comorbidity. We have FRED forms. FRED for us is a faster respiratory assessment. They go from a chest x-ray to a CT on a 2-week pathway. And it revealed a tumour in his right lower lobe. So the message really from this is, don't just think that worsening symptoms always means worsening COPD. And I say that because I've heard that so often, and I think, you know, I'm not questioning any of your clinical judgments. I'm sure you're all amazing, but consider things like weight, glands, hemoptysis, thinking about those things. I think over my career, I have diagnosed a lot of CA lung from COPD patients and patients who are reluctant to tell us about hemoptysis. And I find it fascinating. You know, they're not all, they just accept symptoms. So thinking about that is really important. So that's the story with him. Harry, 72-year-old, past medical history, hypertension AF, got diagnosed with COPD, and he's got a centre predicted, 28% predicted. So he's very severe. He's a very severe COPD patient. He holds his health. So this is an example of the patient we were talking about earlier. So his SpO2 on air is very good when he's well, at 94%. He doesn't desaturate when he walks. So one way to check is if somebody sits in your room, 94%, but they walk up the corridor and back again and they desaturate down to 90, they need to be assessed. So if they drop below 92 and by 4 points, 4%, then you need to assess for ambulatory oxygen. So in our area, that's our criteria. So with Harry, when he exacerbates, he always used to go down to 88, but he tolerated it. He did well on it. He didn't really struggle with that. We knew Harry always used to come back and we'd check. He was having more frequent exacerbations. He'd been in hospital twice in the last 6 months. He had a real adverse thoughts about going into hospital, and I think this was really important in his care. He was on Foster 2 puffs, PMDI and Broltus, so that's where he sat. He'd had a chest x-ray, nothing sinister was seen. He'd had a CT scan when he was in hospital on one of the admissions. He'd not lost a lot of weight. He'd got no new other cardiac or other considerations. So this guy, as I'm sure you can think, is a decline in COPD, severe, going into end stage. What do we want to do with him? So we switched his Simply to Trimbo. We made that open triple back into a close. That made it much more simple for him. He liked the PMDI with aerochamber. We could have given him the Nexthaler, but he liked the aerochamber. He used his aerochamber for his SABA use. So in between, when he was needing extra bronchodilation, he would do up to 4-6 puffs, one at a time through the thing. We did consider pulmonary rehab, even though he's getting down the way. It's interesting to somebody's asked what Broltus contains. Broltus is a LAMA. It's a long-acting antimuscarinic. So it's the same as Spiriva. It's tiotropium. So with him, we looked at community respiratory input. We looked at chest clearance to help him. We considered pulmonary rehab. He did actually go. This guy was quite severe COPD. We spoke to the consultant via our community team, and we looked at theophylline, which we're not now using, and azithromycin. We popped him onto azithromycin, and he had that on a Monday, Wednesday, Friday, because he wouldn't come out of an exacerbation. He'd go straight back into another. And then we talked about what did they want as a family and where did they want to go with this. And this is looking at them going on the gold standard framework. What are their wishes? What are their concerns? We've optimized his treatment. He went on to azithromycin. We popped in a mucolytic for him. We encouraged him with the physio chest techniques and helped him with that. We gave him a lot of education through pulmonary rehab, and within the pulmonary rehab they do talk about power of attorney, end of life, what to expect, and living wills, etc. So he did go on that. Now Harry sadly is no longer with us, and he did decline quite rapidly, and there's never a guess of how are they still going to be here in 12 months. We always ask that question, and there isn't always a predictability with him, but with Harry, he didn't want to go back into hospital. He didn't want any more interventions. He was happy to do what he could when he could, and decided that that was where he wanted to be. And like I say, we just safeguarded him. He ended up on end of life pathway and was cared for that, bless him. So yeah, we've got to think about that end of life for that patient. There are lots of other things in end of life that we consider with COPD. Looking at the anxiety is really one of those things that you need to think about for them patients, because this feeling of breathlessness is horrible. So that's him. Now I've got Glenda. I'm aware that this is the last one I'm going to do because I'm aware of time. So just going to quickly whiz through Glenda. She's a lady who was in and out of A&E, exacerbating increased dyspnea, COPD patient. She was a real interesting case, because sometimes when she came, her SpO2 would be 94, she was really well, she'd be great. Other times she would be terrible, she'd drop her SpO2, and when she was down at 88, she was very symptomatic and was very impacting for her. So she was on Trimbo. We'd simplified it because she was an anxious lady. And we went down the route of let's look at what's underlyingly going on. And she'd got severe anxiety. Yes, I'll come back to the oromorph. That's fine. We looked at anxiety with her, and it's really interesting, and I've put her in just to make you think about it. She'd been brought to myself because I was doing a complex clinic to say she's in and out of A&E, nobody can do anything with her. I spent a lot of time educating her. She wouldn't go to pulmonary rehab. She got a disabled son. She got a lot of underlying mental health that had not been identified. So we actually looked at her mental health thing, and 80% of her admissions weren't exacerbations, they were fear driven. So what we did with her is we educated her, we simplified her regime, we put her onto an SSRI, and we had a community mental health referral for CBT. And over the period of time, we did offer pulmonary rehab, but she wouldn't go. We had a community respiratory team case management with her, and over time, over the following 4 months, from going into A&E 5-6 times a week, and I don't exaggerate with that, I got her to a point where she didn't go in for 5 months, and she was so proud of herself. So what I'm saying is always think about anxiety and depression with these patients. And it did take a lot of education, and it took a lot of time, and we gave her open access. So it's difficult, but that change in her CBT and her SSRI hugely changed her. Which was fantastic. A&E were well happy, and she used to come and see me, and she was a very broad Lincolnshire lady, and she'd go, all right, Duck, I've not been in hospital, Duck, I've not been for weeks, and she was just beautiful. She's not with us anymore, but I always remember her as an example. So somebody asked a question, Abra, go back and tell me what that was about oromorph, I think.
Yeah, sure. From Charlene, can I check about PRN oromorph use for breathlessness and COPD, and when would you consider it?
Yeah, so yeah, we do use it very, very end of life. For obviously we've got that whole oromorph is great, but it's also respiratory. It affects the respiratory drive, so we have to be cautious with it. I have used it alongside lorazepam and sort of more anti-anxiety stuff as well. I think it's really important that it's end of life only, and we use it small doses initially. It calms patients down, and that breathlessness, that anxiety driven breathlessness, as well as the physiological elements of change, are very impacting on patients. So brilliant. I've used it. It's always in end of life though. So, and you also, somebody just asked another question about, I
Yeah,
did see it flash and it went off again. What was that one?
that's all right. So, Mojabin asked a question, what are your thoughts on patients buying their own nebulizers privately and then asking us to prescribe the nebules? The
Yeah.
main concern is around infection control and hygiene of the equipment, particularly the risk of contamination, such as aspergillus. I've had a few patients asking about this recently and wanted to get your view on this. Thank you.
Interesting, whoever that question's from, really interested. I've had less recently, but yes, patients buy their own, they then want us to do it. In Lincolnshire, we can refer for nebulizer assessment. I would say only end of life patients need nebulization. We can give them salbutamol through a spacer with a mask, and that really decreases. It takes away that need to inhale, which is why patients like nebulization. I totally agree with you. We've got increased risk of infection if they're on nebulization. They have to have machine service, they have to change. So if you have an exacerbation and you're using tubing, that needs to all be changed in between. I personally try and persuade patients, and like I say, I haven't had one for a long time. I move them to a PMDI salbutamol with a spacer and a mask, and really educate them as to why. But end of life, our community team do use them in end of life situations. So, I'm not saying they're never, never, of course I'm not, but yes, what's the word? Don't encourage that going forward, and have a good, honest, open conversation with patients about how they're increasing their risk of increasing infections and all of the complications that come with that. So hope that answers that. So what I'm going to do is just, yeah, does
Another question just come through. Did you see that, Pauline? Or yeah. From Army Solgo. There seems to be no clear pathway within my trust for referral for a clear diagnosis of possible asthma to respiratory. What are your procedures? See, going a bit
okay,
there.
so repeat that. So there's nothing that they're saying is a pathway from asthma to COPD. Is that what you're asking me? I think that's what was said. So with regards to if that is just abroad, just go back on that question. I missed a little bit of what you said.
Sure. There seems to be no clear pathways within my trust for referral for a clear diagnosis of possible asthma to respiratory. What are your procedures?
Okay, so for asthma diagnoses, then we don't have a great pathway. A lot of it's done in primary care. So if I've got a COPD patient and I'm thinking there's an asthma element, I'm looking at blood eosinophils. I'm looking at that historically. I'm looking to see what their pathway was before they got COPD. If you're talking pure asthma, then the pathway should be that we're doing spirometry reversibility, we're doing pheno. We have pheno accessible to us. I hope you guys do, because it makes such a big difference. Remembering that both of those can be negative. They do serial peak flows, so they have that. If I'm still unsure of diagnosis, then we have to go secondary care. In children, we have a children's and young persons pathway, which we can go to our diagnostic centres, and that has only just started for asthma diagnosis, and there is a plan that will potentially be thrown out to asthma diagnosis if we can't establish it in general practice. So that's our pathway. If they've got asthma listed as asthma and COPD, I always treat asthma as your first diagnosis. Oh, what a shame you don't have diagnostic centres. Hope you get them soon. We've only had them 6 months, but it makes a big difference. So sadly, that would all have to be done in practice or a secondary care referral, which, as we know, takes forever. If they've got an asthma and COPD diagnosis, I always treat with an ICS. Do not, and I've seen this happen, do not take out the ICS, because we need to underlyingly treat it. There's work looking at the different phenotypes of COPD, as I hinted to along, and gold guidelines are looking at blood eosinophilia levels within a phenotype of COPD and whether they would be suitable for biologics, and biologics will come in that. But that's a very small percentage of patients. I always keep them on dual register or on overlap, depending on how your practice wants to monitor that. And I always think about that. So as they're asthma COPD, remember they can have more salbutamol, but we always treat with an underlying. I always go Trimbo, because I think we've got the triple there. We're bronchodilating them. We're hitting the small airways. We've said that the small airways are important in asthma and in COPD. So that works really, really well for me. So is that not the same as COPD with asthma features? Yes, it is really. Absolutely the same, dependent upon the element of their disease. So if I've got a patient who is severely asthmatic and asthma has been the biggest predictor, then let me think about a patient that I've got, let's call him John, and he'd got asthma, wasn't controlled. We know there's a COPD element. He had been a smoker. What we've added into his treatment pathway, though, is he's on Montelukast. We've actually looked at, does he need, so we've moved him to the Trimbo higher dose because he needs the extra steroid for his asthma element. So, but he has still got COPD, because even though he's massively treated, and this has come from secondary care, he's got COPD underlyingly. So he's got some airway damage that has already occurred. So I think in summary to that, treat the asthma as the first line always. If they're stable and okay with asthma COPD, then triple as standardization, triple asthma ICS LABA-LAMA is a perfectly suitable way to go forward with this patient. But like I say, they may need some added bronchodilation. They may need a anti-leukotriene receptor. Those are the other elements that I've got to think of, really. I've got a couple of patients, one who is definitely COPD asthma overlap, but we have ended up giving them more steroid, and that's come from secondary care as well. So they've gone on to the Trimbo higher dose because they feel that the asthma is the bigger problem with that patient. It's very difficult to look at individual cases. Any particular question around that particular one, or any other questions? I hope that answers.
The only other questions come up from Amy around I hear biologics are coming in to treat COPD. That was the only other question on there.
Yeah, they are. So biologics in asthma, when I talked about asthma to you guys recently, definitely we're the eyes and ears. We need to find the patients. If they're exacerbating patients, we've maximised and optimised them onto their inhaled therapies, and they're still having to have 2-3 courses of pred a year. They need looking for biologics. COPD, then yes, biologics are coming. It's new, but they're coming, and they're looking at that phenotype of patient. Is there more of an eosinophilic driven patient that would respond well to biologics? So they're on the way. Not doing more than that, really.
Just another question come through from Omisogo. Again, I was told we shouldn't prescribe nebulized in GP practices, I think, or GP by a respiratory nurse, and should be only prescribed by respiratory nurses.
I agree. Ours can go for nebulizer assessment to the respiratory teams, and they're the ones that can decipher if they have it. I can't tell you the last time I actually gave nebules out to anybody in COPD, if I'm honest. There's been a lot of work done over here with the nebulizer clinics, and I think the community teams are very much, we shouldn't be giving nebulization out to patients. So yes, it was a practice of 20 years ago, which we now need to be moving away from. And in asthma, please. It's terrible. It actually causes asthma deaths, asthma nebulization in asthma. If patients have one at home, they rely on them and they don't seek advice at the right times. So that's good.
Pauline, unfortunately, I think we're out of time. Coming at 2:01.
Guys, it's so nice to speak to you all. And any questions, if you want to give them to Abrar, I can always have a chat with him later, and he can come back to you. Thank you for your time.
Nice. Thank you so much. And can I just say to everyone to give Pauline a virtual clap if that's possible?
See, somebody has. I've got some virtual claps coming through.
Oh, wonderful. Thank you. And from ourselves, from Chiesi, myself, Abraj, and Pauline, we're really pleased today. You know, with the talk and the interaction, the level of interaction we've seen today, really appreciate it. So thank you, Mel, Craig, and obviously Pauline speaking today for us. We really appreciate it. Not going to take long, just 10 seconds. From my point of view, you've got my contact details. Feel free to contact me. Happy to catch up with you in terms of local meetings, catch up, update, lunchtimes as we do. Breathing well range, I couldn't show you on because I had a blur on the camera before. We offer these things free of charge. Intro to COPD booklets, intro to asthma booklets, and also the peak flow diaries as well, and also the placebos as well. So we offer all of that free of charge. But no, thank you again for today. Thank you to the Training Hub.
Thanks, everybody.
Thank you. We really hope you found it valuable.
Pauline.
It's lovely to see you. Great group of people over there. Keep up the good work. I hope you get a diagnostic centre soon.
Got loads of thank yous. So lots of lovely messages. So yeah, keep those coming.